The BABU will be joining with us another 5 minutes. But meanwhile, we will not waste time. We will start the program. Our Professor SELWYN and Michael will be here. They will initiate the discussions on the thyroid. Then as soon as DAYANANDA Babu sir reaches, he has already reached, but he will take 5 minutes. So we will continue with the programs.
Here within 5 to 10 minutes. So he will give a brief introduction about thyroid. Okay. So till then we will ask you some questions. Okay. So what is thyroid? Thyroid is the endocrine gland. It secretes thyroxine T3 and T4. So it secretes hormones by negative feedback. Okay. So what is TRH? TRH Nana. Thyrotropin releasing hormone, which is secreted by hypothalamus. Okay. So that TRH stimulates pituitary gland, anterior pituitary gland to secrete TSH. What is the normal value of TSH? Over bookle or mar 0.3 to 5 intercon bookla 0.5 to 5 international units. Okay. So that TSH stimulates thyroid gland to secrete T3 and T4. Okay, and the 5 steps iodide trapping, the steps you might have studied. So why MNG occurs? Multinodular goiter occurs. So whenever there is a stimulation by TSH, there will be diffuse hyperplasia. Okay, but whenever there is fluctuation, some follicles will be more active and some will be less active. So some daughter lobules will be formed. Okay, so daughter nodules will be formed. So that will result in or disproportionate hormone secretion. So you will get nodules here and there. Okay, so that is the mechanism by which multinodular goiter occurs. Okay. So isthmus la right side lobe left side lobe. What is the shape of the thyroid gland? So when there is a diffuse enlargement, it will be more of butterfly shape or thyroid gland shape. Okay. What is discordant nodule?
Embryology. So, embryology of thyroid, anyone? How thyroid gland forms? Thyroglossus duct arises from where it is situated? Thyroglossus duct forms, then from the median bud it descends caudally towards downside towards the neck, more towards the left side through or nearby the hyoid cartilage, forming hyoid cartilage. Okay. Then how parathyroid are formed?
How many parathyroids are there?
Which arises from the third and which arises from the fourth pharyngeal fossa? Why it goes down? It is formed from the third pharyngeal fossa, right? Then why it goes down? Along with thymus, it descends. So it goes further down. That is the reason the inferior parathyroid arises from third pharyngeal fossa, but it goes down more. Then what is the size of the thyroid gland? Weight of the thyroid gland. Hey. About 20 to 25 grams. What is the functional unit of thyroid? Is thyroid lobule, which is supplied by an individual arteriole. Okay. Inside which thyroglobulin is saved as colloid. Okay. How many follicles will be there? How many lobules? Roughly around 40 lobules will be there. Then blood supply.
Superior thyroid is a branch of, when you write the exam, you have to write superior thyroid artery, which is a branch of, okay. All know superior thyroid artery, inferior thyroid artery, but you should write is a branch of which artery, okay. Superior thyroid is a branch of?
Sure.
Then inferior thyroid artery?
Trunk. Okay.
So blood supply means not only artery, it includes venous drainage also. So venous drainage, superior thyroid vein drains into middle thyroid vein, inferior thyroid vein, left brachiocephalic. Okay, only one, both drains into the left brachiocephalic. Okay.
So, okay, when diffuse enlargement of goiter occurs in physiological condition.
Before that,
puberty, pregnancy. Then okay, what is goiter? Diffuse enlargement of thyroid gland is called as goiter. Physiologically, it occurs during puberty and during pregnancies. What is the most important nerve which passes through it? Why it is important? What will happen if it is injured during any surgeries? Strider. When strider will come?
so unilateral, bilateral, you have to tell like that. Okay, when unilateral involved, what happened? So unilateral means person for voice. Bilateral means strider.
Where it will be located? Recurrent laryngeal nerve. It will be located in the tracheoesophageal groove. Okay. Only when the both nerves are affected or injured during surgery, patient will go into strider. Okay.
Respected professors and one and all present here, I am here to present the clinical examination of thyroid case. So my patient is a 46-year-old female who is a housewife belonging to socioeconomic class 3 from Medalam. She came with the chief complaints of swelling in the anterior aspect of the neck for the past 2 years. The patient was apparently normal before 2 years, after which she developed a swelling in the anterior aspect of the neck. She visited a private clinic for the swelling, and a TFT was taken, which was found to be normal. So the patient left the swelling untreated for the past 2 years. And so the swelling was initially small in size before 2 years, which then gradually progressed to attain the current size. And there is no sudden increase in size of the swelling recently. And the swelling is not associated with pain or fever. The other positive histories of the patient are exertional dyspnea, which is grade 2 of NIHA classification, and history of palpitations, history of excess sweating, history of EC fatigability, history of loss of weight in the past 1 year. And the patient also complains of menstrual disturbance, that is a heavy menstrual bleeding for the past 3 years. And she visited a private clinic where she was diagnosed with anemia, and she was advised to take a USG. But since the patient did not proceed with the following investigation, the cause for the heavy menstrual bleeding was not ruled out. So there is no history of dysphagia, there is no history of hoarseness of voice, syncope, stridor, heat intolerance, there is no history of pedal edema, no history of diarrhea, tremors, weakness, there is no history of loss of appetite, no history of cold intolerance, constipation or puffiness of face, there is no history of chronic cough and hemoptysis, no history of jaundice, no history of any bony swellings, and there is no history of any swellings in the neck. Past history, she is a not a known case of diabetes mellitus, hypertension, TB, epilepsy, asthma, and any heart diseases. The only surgery she had was LSCS with the puerperal sterilization, which was done 19 years back. And there was no history of irradiation to the neck. There is no history of any chronic drug intake, and there is no history of food or drug allergy. Personal history, the patient consumes both veg and non-veg diet, and there is no history of excessive intake of raw Brassicaceae family vegetables. There is no history of smoking, no history of alcohol intake. Normal and bowel and bladder habits. There is normal sleep pattern. Family history, total number of family members are 4. She lives with the husband and 2 children. She has a biological sister, and there is no complaints of similar thyroid swelling in any of the first degree relatives. So menstrual history, she attained menarche at 15 years of age. She had a normal cycle, that is flow for 4 days, which for every 30 days before 3 years. For the past 3 years, she is having heavy menstrual bleeding, in which the cycles occur every 15 days, and she has a flow for 4 days, and she changes 6 to 7 pads per day. And obstetric history, the obstetric code is P3L2. And age at marriage is 24 years, age at first childbirth is 24 years, and age at last childbirth is 27 years. And both the first and last delivery are LSCS. And second delivery is normal vaginal delivery, and the fetus died immediately after birth due to fetal distress. So summary of history, a 46-year-old female came with the complaints of swelling in the anterior aspect of the neck for the past 2 years, which gradually progressed in size with weight loss in the past 1 year associated with the palpitations, excessive sweating, and EC fatigability. The patient also complains of heavy menstrual bleeding for the past 3 years. These are the complaints of the patient. So the probable diagnosis of the case is a thyroid swelling. So examination part, in general examination, after getting consent from the patient was examined in a well-lit room.
1 minute. So what is the provisional diagnosis? It's a thyroid swelling. From history wise, what is our provisional diagnosis?
Sure, it's a thyroid swelling. From the history wise, there is no hyperthyroid or hypothyroid features. So it is a non-toxic thyroid swelling.
What you have mentioned as weight loss
Sir, but,
with palpitation.
Yes, sir, but
why palpitation?
the
Excessive
patient also
sweating?
has anemia, so those symptoms could be because of anemia, for which the cause is not ruled out because of heavy
excessive
menstrual
sweating?
bleeding. Sir?
Excessive sweating.
So anemia can cause.
Anemia can cause sweating.
But there is no other history suggestive of hyperthyroidism like heat intolerance, diarrhea, tremors, and weakness. So
From history, how do you know anemia?
sir, she still has a heavy menstrual bleeding, sir. And she also has, she is diagnosed with anemia, and she is not currently on any medications also. So probably due to anemia, most probably.
She is non-anemic.
Yes, sir, for the past 1 year.
Mentioned here any history?
Sir, in history, I have mentioned in the menstrual disturbance, anemia, diagnosed with before 1 year.
For which she is taking any medication?
No, sir, she is not under any medications.
So, if at all she was diagnosed for anemia, means you should have mentioned it in the past history that she has been diagnosed with a case of anemia but on not on any treatment. You should have mentioned it in past history, right?
Present history. No, anemic.
And without going for examination part, you cannot confirm that she is anemic, right? அப்படிதானே?
So what are the drugs that can cause goiter?
Lithium, amiodarone, and iodine.
Iodine or iodine deficiency?
Iodine deficiencies.
I'm asking only drugs. So what are the drugs? Any anti-tuberculosis drug? Anybody in the? Any anti-tuberculosis drug that can cause goiter? So it's a second line anti-tuberculosis drug, PAS, okay, right. So what are the signs of, what are the, in history, what will you ask for thyrotoxic features?
So thyrotoxic features, for primary thyrotoxic features related to CNS, history of tremors, weakness, history of insomnia, and the patient can also be hyperexcitable. Then
we have in our midst our Professor DAYANANDA BABU, one of the very senior most DIANs in the surgery. He has served in almost all positions as a professor, surgery, dean of a medical college, and professor emeritus. And he is very well respected across the country because of his book on the surgical pearls, which is one of the very third edition. Now he is on the preparation for the fourth edition book is also getting ready. So we are fortunate that Professor DAYANANDA BABU, he is also been Endocrine Society of India, the president of the national president of Endocrine Society. So he is going to talk to you on thyroid. So use this opportunity at the end of the class. If you have any doubts, we will have some discussion. You can ask doubts to him and on the endocrine chapters, which he will be able to explain to you.
so secondary thyrotoxics can associated with serious symptoms, that is palpitations, dyspnea, syncope, and pedal edema, and it can also be associated with the atrial tachycardia, atrial fibrillation, and which can be paroxysmal or persistent. And
okay, from this you have mentioned some thyrotoxic features.
yes, sir.
Okay, any of these features are present in our case?
Palpitations present, sir, which is a symptom of the secondary thyrotoxicosis, and also exertional dyspnea, and which are symptoms of thyrotoxicosis, secondary
So what I am
thyrotoxicosis, easy
going to say is
fatigability also,
don't
and
say
loss of it.
it may be a thyrotoxic feature. So don't say it is because of anemia. Okay. So from its history, both are possible. Okay. Huh? Just to tell the summary of our case. Summary and diagnosis. Like examination. So tell the summary of the history and go for examination.
So summary of the case, a 46-year-old female who came with the complaints of swelling in the anterior aspect of the neck for the past, progressed in size, weight loss in the past 1 year associated with palpitation, excessive sweating, and easy fatigability. The patient also complains of heavy menstrual bleeding for the past 3 years. So general examination, after getting consent from the patient was examined in a well-lit room. The patient has a normal build but poorly nourished. Hydration is fair, pallor present, no icterus, no clubbing, no cyanosis, no pedal edema, no generalized lymphadenopathy, no eye signs, and no tremors or tongue fasciculations. Vitals, pulse rate 82 per minute, which is normal in rate, rhythm, and volume, and respiratory rate is 14 per minute, and blood pressure, it is 107 by 69 mmHg, which is measured in the left arm in sitting position, and the patient is afebrile and JVP is not elevated. Height is 156 centimeter, weight is 43 kgs, and BMI is 17.69. Local examination. After explaining the procedure to the patient, the face and neck was well exposed for the examination. On inspection, patient is in sitting position and examined from the front. A well-defined irregular swelling of size 5 cross 6 centimeter with nodular surface was seen in the thyroid region. The extent of the swelling is it laterally extend till the right and left sternocleidomastoid muscle, and superiorly it is extend till the thyroid cartilage, and inferiorly it is 2 centimeter from the suprasternal notch. The skin over the swelling is normal, that is there is no scars, sinuses or dilated veins. The swelling moves up with deglutition and does not move up with protrusion of tongue. The plane of swelling is deep to deep fascia. The lower border is seen and the trial sign is negative, the trachea is in midline. There is no visible pulsation or no other visible swelling is present in the neck. This is a swelling, picture of the swelling. The palpation, the patient is in sitting position with a slight flexed neck and palpated first from behind and then from the front. There is no local rise in temperature, there is no tenderness. Inspectory findings of size, shape and extent are confirmed on palpation. Two film nodules with well-defined margins are palpable, one on the right lobe and other on the left lobe. The largest nodule is on the right lobe, measuring 4 cross 3 centimeter. Lower border is palpable, trachea is in midline, carotid pulsation felt on both sides, so Berry's sign is negative, and no palpable thrill over the superior pole, and Koch's test is not done. Auscultation, no bruit heard over the superior pole of the thyroid. Examination of regional lymph nodes, there is no palpable lymph nodes in the neck, and the examination of oral cavity is normal. Other system examination, CVS, S1, S2 heard, no murmur. RS, normal vesicular breath sounds heard, no added sounds. Abdomen, soft, non-tender and no organomegaly. CNS, there is no focal neurological deficit. Summary of the case, she is a 46-year-old female, came with the complaints of swelling in the anterior aspect of the neck for the past 2 years. Weight loss in the past 1 year associated with palpitations, NIHA grade 2 exertional dyspnea, easy fatigability and excess sweating. On examination, the swelling moves up with deglutition and 2 nodules were palpable in the right and left lobe of thyroid, with the largest nodule in the right lobe measuring 4 cross 3 centimeter. There were no regional lymphadenopathy. So the diagnosis is a case of non-toxic, non-malignant, multinodular goiter with no pressure symptoms, clinically in euthyroid state. Investigations.
Why you said that this is thyroid?
So because the swelling moves up with deglutition, and the swelling is deep to the deep fascia plane of swelling, and the swelling is in the thyroid region, that is in the anterior aspect of the neck, bounded superiorly by the thyroid
In
cartilage.
relation to which triangle you get thyroid? You said thyroid region from the very beginning.
Yes, sir.
There is a swelling in the thyroid region, something you said.
Yes, sir.
So in which triangle you get thyroid?
Anterior.
Which triangle?
And
Anterior, of course, there are divisions of the anterior triangle. So which triangle? Somebody?
muscular triangle.
Muscular triangle. So how do you know it is in the muscular triangle? Did you, how did you ascertain the plane of the swelling?
So plane of the swelling is assessed by asking the patient to extend the neck. If the swelling disappears on extension of neck, the swelling is deep to the deep fascia. If it is prominent, it is superficial to the deep fascia.
Which my book also is describing. But did you check the plane in relation to the muscle, sternomastoid? That is the muscle which you can contract.
We can assess by contraction of sternocleidomastoid.
Did you try that?
Yes, sir.
But you didn't mention anything. What happens when you are contracting the sternocleidomastoid?
On contracting the sternocleidomastoid, the swelling is deep to the sternocleidomastoid, so it disappears on contraction of sternocleidomastoid.
It will disappear. But plane, whenever you say plane, you don't say disappear. You can just say
it becomes less prominent.
Less prominent. You said trial sign. What is it?
Trial sign on for
That is
tracheal
wrong.
deviation.
It is trail.
Trails.
It's not trial. What is that? Because you have written trial sign. Just go back. I saw that you can control from here. You said trial sign negative. What is trial?
Trail sign.
It's a name of a person. It is trails. TRAIL apostrophe S, trail sign. What is it?
Sir, this is for
What is
assessing whether trachea is in midline or any deviation of trachea present. If any deviation of trachea present, on the side of deviation there will be prominent sternocleidomastoid.
The sternocleidomastoid
Mastoid will be
become
prominent on the side of
Okay.
tracheal deviation.
So that is not trial. Something else again I saw you said from where you had front or behind you
Behind palpation from the behind.
behind. You don't do any
Inspection
palpation.
from-
You don't do any palpation from front.
Will do, sir. Cryle's method will.
What is Cryle's method?
For Cryle's method, we'll keep the thumb over the swelling and ask the patient to
That is
swallow
to know the
for
details
nodularity.
of the nodule. That is Cryle. Any other method?
Lahey's method also
What
will do
is
from the
Lahey?
front. Lahey's method for palpating the individual lobe of thyroid will for palpating the right lobe of the thyroid, we push the right lobe of the thyroid to the left side and palpate with the left hand.
Okay. So I think you know. What is Coccus test?
Coach's test.
Did you mention that?
Yes, sir.
Not done. Why?
Sir,
Any problem?
it
You are taught like that? No, that is Coccus test not done. Why?
Sir, it will cause dyspnea.
Your professor told? Maybe, I don't know, because some professors say better not to do. So I don't know, that is why I'm asking. Somebody told you not to do?
Usually,
Eh?
since it causes dyspnea, usually it will not done.
No, you gentle push only. You don't, your aim is not to harm the patient. Gentle pressure on the lateral lobe, nothing will happen. So that is why maybe somebody told you carotid pulsation, very sign negative. Okay. So because of any other reason, for one is the plane, second is movement, third any point, what I will say is the anatomical position. That is why I asked, you should know the anatomical position. You said anatomical position. Why it is moving with deglutition?
So because because of the ligament of Berry, which is a pretracheal fascia condensation in the posterior surface of the gland, which attaches the thyroid to the cricoid cartilage, and also because of the muscles thyropharyngeus and cricopharyngeus, which are attached to the thyroid cartilage and cricoid cartilage. On deglutition, these muscles will contract and pull the thyroid cartilage and cricoid cartilage. So because of the ligament of Berry, the thyroid gland also moves up with deglutition.
Thyroid, the cricoid will move up. Cricopharyngeus and thyropharyngeus, right? So that is the reason. And what was the consistency of the swelling?
Firm inconsistencies.
Eh?
Firm inconsistencies.
And your diagnosis is?
It's a non-toxic, non-malignant
But
multinodular goiter.
before, I think in the history you mentioned some toxic symptoms, intolerance to, just overheard. Excessive sweating, palpitation, easy fatigability, loss of weight. These are all signs of toxicity.
Yes,
You
sir.
agree or not?
Yes, sir.
But why you are not mentioning it in the...
Sir, because the patient is a diagnosed anemic patient for the past 1 year, so I thought these symptoms might be due to anemia. So,
anemia?
because
You are presuming.
yes, sir. Because
Loss of weight, what is the cause for loss of weight? That also anemia. Any increase in appetite?
no, sir, normal appetite.
Normal appetite. Okay. But loss of weight, what is by definition loss of weight?
Loss of weight, the patient does not remember the exact weight of the patient.
Definition of loss of weight.
The clots will become
Eh?
more than
Unintentional loss of weight of more than 10%
10% of the weight in the
over
last 6
the
months.
last 6 months. So that is there. What is the weight of the patient?
She's 43 kg, sir.
40?
3 kgs.
Okay. So with these symptoms, I don't know, what is the pulse rate?
Sir,
Pulse rate?
pulse rate 84.
No tremor, nothing.
No, sir.
Okay. Sir, you proceed then. You can ask. Okay. So what your diagnosis is?
Sir, diagnosis
Come on.
non-toxic, non-malignant multinodular goiter with no pressure symptoms, clinically new thyroid state.
Clinically euthyroid. Okay. So how do you proceed? Multinodular because of 2 nodules. Eh?
Yes, sir.
Right. How do you proceed?
So first,
How many minutes total? Okay. Okay. So how do you proceed?
first we do investigations.
What investigation?
First is thyroid function test we'll do, in which we'll see if, free T3, free T4 level and TSH level. And next is we'll do a USG neck, and then X-ray neck, and we can do indirect laryngoscopy in ENT examination.
And
FNAC.
FNS. See, just like what is triple assessment?
So quad, triple,
What is triple assessment?
clinical assessment, radiological assessment, and histopathological assessment.
For which condition?
Sir, is for breast,
Breast.
thyroid quadruple assessment.
Similarly, thyroid also quadruple assessment. What is quadruple assessment?
We'll do
Clinical.
clinical, radio imaging, histopathological, and
Clinical thyroid function
thyroid
test.
function test, radiology.
Imaging, not radiology, imaging. And
Histopathology.
FNAC. Repeat once again.
Clinical examination, thyroid function test, imaging, and FNAC.
FNAC. So here, what is the value of TFT? Any idea?
No, sir, on the blood report has not yet
Not come. Okay. So after that, depending on whether it is toxic or not, you proceed. You will presume that the thyroid function test is normal. It is euthyroid. And next investigation is
We'll do
imaging. Imaging.
F
Ultrasound.
thyroid function test, then ultrasound.
Ultrasound. Always you should do ultrasound. Why?
Sir, ultrasound to determine the consistency, whether it's a solid or cystic consistency.
Not consistency. To rule out
Impalpable
malignancy.
nodules.
Malignancy. By doing ultrasound, you know whether this nodule is problem or not. Why they are coming to hospital? Fear of malignancy only. Eh? So do ultrasound. What will be the ultrasound finding in malignancy?
It is a hypoechoic mass with increased vascularity, and there can be microcalcifications. And,
Very good, very good.
if it is a malignancy, there will be lymph nodes. In lymph nodes there will be loss of fatty hilum, and it will be round in shape.
Okay, forget about lymph node. You know about that.
Then
But any
the
other
swelling
feature?
will be taller than wider.
Very good, very good. Even my PG will not. You have studied the thyroid for a long time, maybe. I thought you don't know all these things, UG level, but you are answering at PG level now. Okay, go. So, hypoechoic nodule, 1. That means your teachers are good. You are being well trained by your teachers. So, So, hypoechoic plus 4 things. Hypoechoic is suggestive of malignancy. 4 things. One is microcalcification, which you mentioned. Second is disrupted rim calcification. That is the second thing. Third, you said taller than wide. Fourth is irregularity of the border. So, 4 things. So, the hypoechoic nodule with a few of these features, one should strongly suspect malignancy, and then you do a sono-guided FNAC. Whenever you say ultrasound, you say high resolution ultrasound. High resolution ultrasound is 7.5 to 16 megahertz. So your answer should be, you are good. So you can answer. Instead of saying ultrasound, you say high resolution ultrasound. Followed by, you say a guided FNAC. Because the the sonologist knows where is the problem and then he will. What is FNAC?
So it's a fine needle aspiration cytology where syringe is injected in the gland and aspirations are taken, in which we collect at least 2 aspirations, which we get
You have
6.
learned in pathology what size needle is used? Fine needle means?
25 gauge needle.
Yeah, somebody was telling.
25 gauge
Yeah,
needle is
23 or usually we use 23. You can use finer, more finer also, but 23 gauge you use. And then you aspirate. You should apply negative pressure. So what size syringe you use? Yes? Somebody? Somebody please. 10 cc. 10 cc, if you don't use at least 10 cc, you don't get sufficient negative pressure. And then you get the cells inside and then push it out, make a smear in a slide. And then you have to fix it. How do you fix it?
stain, fixing, right? Stain.
Fixing.
Fix
95% alcohol.
95%.
Where you put the slide in some jar. What is it called? Pathology only. You put the slide in some jar. Yes? Eh? Coplin's jar. Your pathology you recollect. Coplin's jar, stain and look. One malignancy which you can diagnose in FNAC. Mention.
Papillary carcinoma.
Papillary. And what are the features of papillary? Cytological features.
In papillary carcinoma, significant features are orphan annii nuclei, which is a pure empty nuclei. Next is the samoma bodies, and
What is samoma bodies?
calcified deposits of sloughed cells.
Very good, very good. Calcified. I will straight away give you a MS. What is your name? What's your name?
Vijayalakshmi, sir.
Vijayalakshmi. It is calcified clumps of cells. That is samoma bodies. And then nuclear grooves, nuclear inclusions, so many features are. So why you cannot make a diagnosis of follicular carcinoma?
Because in follicular carcinoma, there will be capsular and vascular invasion, which cannot be differentiated in FNAC.
Very good. Can you make a diagnosis of medullary thyroid cancer in FNAC?
Yes, sir. There will be amyloid stroma.
Very good. Again, straight away MS only. They should have some MS, straight away MS course like MCH. Okay, so it is benign. You know that after cytology they categorize into various categories. You know that or not?
Bethesda.
Bethesda,
criteria.
very good. You know that. So again MS level only. It's a Bethesda. And Bethesda they categorize and it is benign. I'm telling you, not malignant. How do you proceed? So depending on your cytology, you take a decision whether it is benign or malignant and then decide. So you said some X-ray, so many things you mentioned. What is it?
Sir.
Some other investigations you.
X-ray neck. and,
What is the purpose?
in X-ray neck,
Hand over. So what surgery you do?
it's in this patient, sir.
For this patient?
In this patient, total thyroidectomy, sir.
Why total benign condition?
Sir, but it's a multinodular goiter which has a high incidence of malignancy, so there can be also
Not high
recurrence.
incidence.
Recurrence.
No, not high incidence. Recurrence, I agree. Why recurrence?
So there will be if after thyroidectomy we'll give a substitution T4 therapy, sir.
No. I'm not asking that. Why you are doing total?
So because of recurrence.
You do total. What are the two most important problems?
Hypothyroidism can occur.
Hypo is not problem. Hypoparathyroidism.
Hypoparathyroidism.
And
Recurrent laryngeal
recurrent
palsy.
laryngeal nerve injury. You know that. So that is the problem is you are not removing the cause. What is the cause for multinodular goiter?
It's iodine deficiency.
You don't know what is the cause.
Iodine deficiency.
Eh? So So many factors are postulated, but you
Can
don't
we
know exactly, you don't know the cause. You are not removing the cause. So if you keep back thyroid, again it will grow and produce recurrence. So your fear of recurrence, and the recurrence usually happens after 10 years, 15 years. Recurrence, then re-exploration will be again a problem. So that is why you are doing total thyroidectomy. So I think
So in this case, you are going to do total
Total
thyroidectomy.
thyroidectomy, sir.
What are the complications you will expect? One already-
Total thyroidectomy, during the surgery there can be hemorrhage and nerve palsy, external laryngeal nerve which is most commonly injured, and then recurrent laryngeal nerve palsy, and then after surgery we will expect hypothyroidism, hypoparathyroidism, sir.
So how will you follow up the case?
Um, it'll take you after 6 months. It'll take you
Well, what will you do immediately after doing thyroidectomy? You have
serum
to
calcium levels.
then?
so. You have done very well. Who is your teacher, surgery teacher?
எல்லாருமே
You are posted to some unit. Who is your unit chief?
7th, 5th unit, 5th,
Eh? Tell the name.
4th unit.
My appreciation only. You don't know?
Sorry.
Who is your HOD?
Sir, Jailal sir.
Okay, very, very nice presentation. And which book you are reading?
Sir,
Which book you are reading?
Bailey and Love for Theory, sir.
Very good, very good. Right, right. Any other book?
So Schwartz.
Sure, sir. Too much.
So I just read. I'll refer for
Oh, very good. Your name is?
Vijay Lakshmi, sir.
You are interested in surgery? Becoming a surgeon? Yes or no?
I like surgery, but I've not thought of it.
Okay, very nice. I think we will wind up. Okay, thank you very much.
Thank you, sir.
I thought it is UG and UG level I have prepared this. Basically, it's a clinical examination of thyroid. And you can ask at any time, any doubt, or after the presentation is over. Esteemed faculty members and dear students. It was a very wonderful session for me because my own students will not present like this. I bring greetings from, this is Gokulam Medical College, and I am in this college for the last 15 to 20 years. Before that, I was in Government Medical College, Kottayam. The history, I don't know. When I came here, she finished the history, so I didn't go to the details of. Age is very important in thyroid. Why age is important? Anybody? Our friend, where is she? The person who was presenting. Your name is? Eh? Vijayalakshmi, come here. I will ask. So, what is the importance of age? Please, you can tell. Age is very important. Because certain conditions, you sit there. See, age is the only malignancy where age is included in the AJCC staging. AJCC, you know that American Joint Committee Cancer. That is the only condition where age is included in the staging system. Previously it was 45. Above 55, there is more chance for malignancy. So also below 20 or 15, especially if you get a male patient below 20 or 15 with a thyroid, there is more chance for malignancy. then all thyroid swellings are more common in females. Why? What is the reason? If you look at thyroid toxicosis, it is 10 times more in females. What is the reason? Yes? Estrogen. There is an estrogen receptor. What is the cell of thyroid? Follicular cell. So there is an estrogen receptor in follicular cell. So all these things are common in females. Then puberty, pregnancy, you get more toxicity. Then another point is carcinoma is not a disease at the old age, unlike other malignancies. So here carcinoma may occur in younger age group also. Then as you have mentioned, primary toxic goiter, usually in young people with stress of puberty or maybe pregnancy, strain, sometimes they will come with psychic manifestations. Geographic factors are there in the history. Endemic areas, I don't know Nagarkoil is endemic or not. Yes? Likely to be, because in Kerala all the districts are endemic. Then of course, in endemic areas, follicular thyroid cancer is common, literature-wise. But we see that papillary thyroid cancer also is common in endemic area. Even though literature-wise, papillary PTC means papillary thyroid cancer in iodine-rich areas. Nowadays, after the universal iodinization program, the PTC incidence has increased. That is why we are getting more of papillary thyroid cancer. And the struma river, some of the areas in something called struma ovary. Struma means goiter only. Then the symptoms of thyroid toxicosis. She was mentioning increased appetite, loss of weight, preference to cold, excessive sweating. There is increased metabolism. Then nervous irritability, insomnia, tremor of hands. The tremor is a fine tremor. And patients will be emotionally unstable. And diarrhea may be there. Cardiac palpitation, tachycardia, dyspnea, all those things, cardiac manifestation, which are more seen in secondary toxicity. You have got primary, secondary. What are the types of toxicity?
Primary thyroid toxicosis and secondary thyroid toxicosis.
One more.
And
Toxic nodule.
adenoma.
Toxic nodule, which is otherwise called
Toxic adenoma.
autonomous nodule. Autonomous nodule. So these are the types of toxicity, but the cardiac manifestations are more in secondary. The nervous is more in primary. And always check whether the hands are warm and moist. And then the eye, the staring look to exophthalmos. Maybe initially staring look or protrusion of eye is there or not, we will talk about. And then there is something called pretibial myxedema, which is nothing but an induration, non-pitting induration of the pretibial skin, which is seen in thyroid toxicosis. This is called pretibial myxedema. And also something called acropathy, thyroid acropathy, which is nothing but the nail clubbing seen in thyroid toxin. That is called thyroid acropathy, along with some swelling of the digits as a result of the periosteal reaction. You know that the primary thyroid toxicosis is autoimmune disease. So it can affect any, including lymphatic organs. You may get lymph node enlargement, you may get splenomegaly. All those things are possible in primary. Onycholysis is otherwise called the plumber's nail, where the tip of the nail will get separated from the finger bed. So that is called onycholysis. It is also called plumber. Have you heard of plumber? Yes? You can sit and answer. The secondary toxicity is called, primary is called, otherwise called what? Graves' disease. Secondary is called?
Plumber's disease.
Plummer syndrome. secondary toxin. So that same plumber, he has done many works in thyroid and toxicity. So this is called plumber's knife. And then there will be myopathy, the proximal muscle weakness. If you ask the patient to get down from the stooping, like get up from a stooping position, there will be difficulty. That is called plumber's sign, proximal muscle weakness, or that is myopathy. And then maybe amenorrhea, maybe polyamenorrhea, or sometimes even menorrhagia. Menorrhagia can also occur in thyroid toxicity. Symptoms of hypothyroidism also you should know. The reversal, increased weight, lethargy, sleep, dull. They will be always very slow moving. Patient will be always sleeping, intolerance to cold, dry skin, puffiness of face, fat deposition in the supraclavicular fossa on both sides and in the shoulder region. So that is one of the typical features of hypothyroid patients. And then of course hair loss, especially the outer 1/3 of the eyebrow. So always you check, especially I always tell that 50% of the females above 50 years are hypothyroid. So just check the outer aspect of the eyebrow. Then this weekend I met one of our anesthesia professors. She said, I've got fat swellings here, both sides. I said, you check the thyroid function test, maybe hypothyroidism. So the fatty humps of back and shoulders, and also constipation, oligomenorrhea, all those things. Pressure effects, especially tracheal deviation she has mentioned. During sleep, whenever there is pressure on the trachea, there will be some nocturnal dyspnea, or the patient, if you elicit, you should ask whether she is getting discomfort during sleep in particular position, or whether she is having postural cough also. So postural cough is typical of retrosternal extension. Very good. So retrosternal extension you should, even if clinically there is no retrosternal extension, there may be a retrosternal. So postural cough is one of the features of retrosternal extension. Then of course dysphagia is uncommon, even though patients will always complain of dysphagia, because there is some, this you have seen this slide? No. So I was not knowing that, even though it was bleeping the laptop. So the symptoms of hypothyroidism which I have mentioned, at least remember the common things, the lethargy, increased sleep, dull, intolerance to cold, hoarseness of voice. Hoarseness of voice is due to laryngeal edema in hypothyroidism. And then of course the fatty humps of back and shoulders, all those things. Pressure effects. This slide came or not? Yes or no? Okay, no problem. Thank you. Pressure effects, postural cough, and then stridor. Stridor is by definition an inspiratory noise. So whenever you suspect stridor, check whether it is inspiratory or not. And then hoarseness as a result of pressure on the recurrent laryngeal nerve. Then coming to past history, the two most important things are, which you didn't mention. Mentioned or not? The ionizing radiation. Mentioned? And radiotherapy. Ionizing radiation, you should know the Chernobyl disaster. After the Chernobyl disaster, many of the population there developed papillary thyroid cancer. So if they are exposed to ionizing radiation less than 10 years, then likelihood of developing the DTC I have written. What is it? Differentiated thyroid cancer. What is differentiated thyroid cancer? Papillary, follicular, Hardal cell. Very good. And then radiotherapy to head and neck, especially for maybe conditions like lymphoma, thymoma. Olden days they used to give for benign conditions also acne, tonsillitis, and they develop malignancy 15 to 30 years after exposure. Another funny thing is, if it is low radiation, they will develop nodules and carcinoma. If the exposure is very high, 2000 rands, it will prevent carcinoma. Why? That will destroy the follicular cells. And then history of autoimmune diseases also. Now the family history again very important. Maybe more than one member may be affected. Then maybe patient maybe from endemic area. There is something called Pendred syndrome. You know what is Pendred syndrome? What is it?
Goiter associated with sensorineural deafness seen in Pendrin mutation.
Yeah. So sensory neural aerial nerves plus goiter. Dysharmogenesis. It's called dysharmogenic syndromes. Medullary thyroid cancer, MEN type 2A and type 2B. You know type 2A, what is it?
Men 2A associated with medullary thyroid carcinoma, pheochromocytoma, and cutaneous lichen amyloidosis.
That is 2B.
Hirschsprung disease.
No, 2A. One more. Hyperparathyroid.
Hyperparathyroidism.
Hyperparathyroidism plus the medullary thyroid cancer and pheo. That is 2A. 2B is the one which you are telling. There is no hyperparathyroidism, only medullary thyroid cancer and pheo. So whenever you get the MEN with a thyroid, remember that you should manage the pheo first. Because pheo is, what is pheo? It's a life-threatening disease, unlike thyroid. So if you operate thyroid with a pheo, the patient will die by intubation, by manipulation of the gland. Patient will go into severe hypotension and patient will die. So always first thing is operation for the pheochromocytoma. Then Cowden syndrome, another condition, familial condition, breast carcinoma, thyroid cancer, endometrial cancer, intestinal hematoma. That is a combination, Cowden syndrome. So whenever you are asked about family, at least you, I'm sure you will mention about MEN, then Pendred's, then Cowden, then so many other, FAP, Gardner's syndrome, so many other syndrome. FAP, you know what is FAP? Polyposis. And the Carney complex, Werner's, even if you don't remember those things, at least up to Gardner's you should know. And some mutations, the BRAF and RAS. BRAF mutation in the papillary thyroid cancer, RAS in the follicular thyroid cancer. Then dietary and drug history. At least you should know a few drugs which will cause thyroid. They may ask you. I have mentioned carbimazole, but PAS, which nowadays you are not studying in pharmacology, maybe you are not using also, the para-aminosalicylic acid, which was an anti-tuberculous drug. Perchlorate, thiouracil, and the most commonly used drug nowadays producing goiter is amiodarone, cardiac drug, that will produce toxicity. So amiodarone induced thyrotoxicosis. So if you are asked, definitely you can say the perchlorate thiouracil are old, then amiodarone definitely you can mention. And then dietary deficiency. There is deficiency of iodine in our water and soil and food. That is one of the factors. Calcium is goitrogenic. The cabbage, which I have mentioned, cabbage contains thiocyanate. And then excessive iodine intake also can produce, iodine intake can produce goiter. Then coming to the general examination, the pattern varies according to, I don't know whether here, some areas they start with the inspection itself. Suppose there is a staring look and exophthalmos from inspection. Before inspection, general examination, they will mention. Or after finishing the your thyroid also, we can go to eyes. Anyway, you have to mention about eyes. And you should know some of the signs, even though so many are described. You should know lid retraction. What is lid retraction? What is lid retraction? Okay, okay, I will go first. So lid retraction, what is lid retraction? There is a part, sympathetic part of the smooth muscle part of levator palpebrae superioris, which is called Muller's muscle. So that the contraction of the Muller's muscle, the upper eyelid will go up. That is that is called Dalrympe's sign. All these signs you should know. And the exophthalmos is due to deposition of glycosaminoglycans behind the eyeball. This is the Nafziger's method for looking. This is a tangential view from behind. The examiner stands behind, and then if the upper limbus, the sclera is seen, then you can say that there is exophthalmos. Then of course how to look for the tremor, I will show. Pulse always is important. Tremor, you have to spread out the fingers, not just always see that the fingers are spread, and if you are not noticing, keep a piece of paper. And to demonstrate the fine tremor, it is fine tremor. Then local examination, I have mentioned the muscular triangle. Then Pisillow's method is there. Most important test, I will say that this is the most important test. Your diagnosis is sure if it is moving upwards with deglutition. Maybe thyroid or thyroglossal cyst, or sometimes the subiod bursa. So why you are making a diagnosis is this test. Sip of water. Always use sip of water, because in the exam you get patients being examined by many students, and finally it will not move. And the second point also is important. If it is not moving, it is non-thyroid. Always move. No movement means it is not a thyroid. Then of course short-necked people, you use the Pisillow's method. This is only for short-necked, keeping both hands at the occiput. Then the Pemberton's test. You know what is Pemberton? For retrosternal extension. Then palpation. First, initially you stand behind, which we have mentioned. Both the fingers of both hands on the side and the thumb behind the occiput or on the head just give a slight flexion of the neck, and both lobes are palpated with 4 fingers on either side. This is Lahey's method, that is, you push, in this case the right lobe is being examined, they push the right lobe to the right side with right hand, and palpation of the left lobe is done. Similarly, the other lobe also can be examined. That is the Lahey's method. Maybe your books are showing, this is my own patient I have taken for demonstration. So that is the Lahey's method. Then the thumb, palpation with, so the Lahey Kreil are done from front. The original palpation is from behind with 4 fingers of both hands. And then the Coker's test is there, plane of the swelling is there, which I will. This is how to find out the position of the trachea with 3 fingers. Did you mention that? You didn't mention. Position of the trachea. Okay, then this is the Coker's test, just gentle pressure. Then the plane of the swelling by contraction of the sternocleidomastoid. Maybe you can contract one by one, left sternomastoid, then right, like that. Or both simultaneously you can examine by applying resistance to the jaw. Ask the patient to push down the jaw. Causes for hard nodule, you should know. In the examination, if you are getting a hard nodule, they will ask. Malignancy, calcification, thyroiditis, hemorrhage into a nodule. These are the 4 causes for hard nodule. You know that? Okay. So what type of calcification you get in multinodular goiter? Dystrophy calcification. Then percussion, they say it is more theoretical. More theoretical. Auscultation, they look for bruit in the upper pole because the superior thyroid artery is there. But your books, Das or Norman Browse, they are saying over the lobe. So I don't want to go to whatever your teachers are telling. I always insist for upper pole. But the books are telling lobe. And then measurement also is important. And finally, the next system to be examined is the cardiovascular. There is something called apathetic hyperthyroidism. You get cardiac manifestations. Patient will be attending the cardiology OPD. There won't be any goiter, but then they do thyroid function test and detect hyperthyroidism in old age. This is called, so old age people with depression, there will be depression. So they may attend psychiatry OPD or they will attend the cardiology OPD. That is called apathetic hyperthyroidism. Then signs of malignancy, I have given 9. You should know, this you should know. 9, that is hard inconsistency, fixity, rapid increase in size, hoarseness of voice, Horner's syndrome. Then the region, the first lymph node to be involved is called Delphic node. Delphic node is nothing but prelaryngeal node. So then Horner's syndrome, you should know the components of Horner's syndrome. Then the Berry sign, she mentioned. Strider due to tracheal obstruction. One more thing which I wanted to ask her, bony swellings. You should always look for, whenever there is, you suspect malignancy, look for distant metastasis. 2/3 metastasis will go to lung. 1/3 will go to the bone. So the commonest place is scalp. It can go to the clavicle or the sternum. All those things can be affected. So this is the signs of, these are the signs of retrosternal extension. On inspection, lower border not visible. On palpation, you cannot get below the swelling. On inspection itself, Pemberton positive. Then percussion over the manubrium, a radiological finally. So confirmation of retrosternal extension is by radiological examination, including a CT, if you suspect. The only indication for CT in thyroid, there is routinely we don't say CT as a part of thyroid investigation for thyroid. The only 2 indication, one is retrosternal extension and second is malignancy, to rule out infiltration of the surrounding structures. Punching goiter is no thyroid gland is felt. You ask the patient to cough, the intrathoracic pressure will push out the goiter which is remaining there. That is called plunging goiter. So you should have, as she mentioned, anatomical diagnosis. The points are given. The pathological diagnosis. Pathological diagnosis, by your palpation you know whether it is a diffuse goiter or a nodular goiter. If it is diffuse goiter, maybe a thyrotoxicosis or a colloid goiter. Two causes for diffuse. Or you will say nodular goiter. A single nodule is called solitary thyroid nodule. More than one nodule, it will become the multinodular goiter. So by clinical examination, you should decide whether it is benign or malignant. Then of course thyroglossal cyst examination, with protrusion of the tongue there will be movement, which is seen only for the thyroglossal cyst. And of course finally the functional diagnosis, euthyroid, hyperthyroid or hypothyroid. So this is the final. Finally you think whether my diagnosis is thyroid or not. Second is pathologically what it should be. Whether it is a diffuse goiter, diffuse toxic goiter, signs of toxicity is there or malignancy is there, those things you decide. And then make a diagnosis, solitary thyroid nodule or multinodular goiter, all those things. And always think of the function euthyroid, hyperthyroid or hypothyroid. And the quadruple assessment which I have mentioned, which we have mentioned, this is the quadruple assessment, cyst. So 50% will be the dominant nodule, 20% will be cancer, thyroid cancer, 20% will be solitary thyroid nodule, and finally 5% thyroiditis, 5% cyst. That is this is few of our cases. The first is multinodular goiter with toxicity. Generally the statement is eye signs are absent in secondary toxicity. Remember, eye signs are absent in secondary toxicity. This is a special case. I don't want to confuse you, but at least remember eye signs are absent in secondary toxicity. If at all, it will be very minimum, maybe some retraction. The right picture is solitary thyroid nodule. This is the left hand picture is carcinoma, anaplastic cancer. Anaplastic cancer. Right side, a skull metastasis. Skull metastasis. Then indications for surgery, at least broadly, malignancy, pressure symptoms, retrosternal extension, toxicity and cosmetic. Any nodule more than 4 centimeter, high chance for malignancy, that also. So these are the indications for surgery. Sir, is it time to stop? 5 minutes, he said. I will. So indications for surgery, and with that I will stop. Thank you very much.